Shall we start? Aref, Sylvia?
Yes, please, doctor. Go ahead, please.
Yes, please.
Bismillah ar-Rahman ar-Rahim. Good afternoon, everyone. I would like to welcome you to this workshop webinar on non-invasive ventilation prepared by Philips. This webinar will start with the basics and the difference of the NIV and the intubation and when is each recommended, what are the pro and the con, indications and the contraindication, and what would be the potential modes to use for each case. Please, for the attendees, feel free to interact by further comments and questions in the chat. And there is a survey. Please fulfill it at the end of this webinar. Our agenda today will be as the following topics to be covered. First, we will speak about the basics of hospital ventilation, invasive versus non-invasive ventilation by Professor Richard. Then the challenges of NIV, possible complication and countermeasures by me, Mohamed Abdelhakim. Then we will take questions and answers. Then by Mr. Aref Hajeer, we will speak about advanced techniques in the management of ventilated patients. Then Professor Teolo will speak about home non-invasive ventilation for different respiratory disorder, how to avoid hypercapnic respiratory failure. My name is Mohamed Abdelhakim El Nady. I am a professor of chest diseases, Cairo University, and I am the medical director of the new Qasr Al Aini Teaching Hospital Chest Department. Now it is my pleasure to introduce my first eminent speaker, Professor Richard Vanzel Smith, professor and consultant pulmonologist, Division of Pulmonology and the Department of Medicine, University of Cape Town and Groot Chul Hospital, Head Lung Clinical Research Unit, University of Cape Town Lung Institute, and we will speak about basics of hospital ventilation, invasive versus non-invasive, what and why. Professor Richard, the floor is yours.
Thank you, Professor Mohammed, for that introduction. Delighted to be with everyone this afternoon or evening. Can I just confirm that you can see my slides and that they are moving?
Yeah, yes, doctor.
Yes, confirm.
Brilliant. So,
Yes.
yeah, delighted to be with everyone across the continent. My job this evening is really to introduce this NIV story, the what and the why, and set the scene for the rest of the speakers who really will go into more of the details in terms of the practicality. We decided to start with a fairly basic introduction, as many people in this webinar may be experienced. There may be others that have not been experienced in NIV, and so if you know what I'm talking about, then I'm just reminding you, and if you don't, well then hopefully I can enlighten you. In terms of conflicts of interests in relation to NIV, really I have none. I spend most of my time not with NIV, although I'm delighted to be participating in this NIV story as it's part of our critical care service. And then just to thank my colleague, now retired Dr. Ricky Rain, for support with some of these slides. So, non-invasive ventilation, what is it? How is it done? And where should it be done really is where I'm going this evening. So you will all know about ventilation, invasive ventilation. When we talk about ventilation, we think of the patient who has a ET tube in and attached to a ventilator. Well, we can non-invasively ventilate. In other words, apply the same types of inspiratory pressure, post-expiratory PEEP pressure to a patient, but not through an endotracheal tube. And so this is where we really talk about non-invasive ventilation, supporting respiratory mechanics without an endotracheal tube being placed. Now, generally speaking, we're talking about nasal or face mask non-invasive ventilation, or potentially helmet-associated ventilation. There are some slightly more rare and not rarely used, the shell or jacket. And some people talk about CPAP as a form of non-invasive ventilation, but really CPAP is continuous positive airway pressure, which really isn't ventilation. So I'm going to focus entirely on ventilatory support, the application of positive pressure through a non-invasive interface. So what are the advantages of NIV? Well, firstly, you don't need to have an endotracheal tube, and the upper airway remains intact. Many of the complications we see with invasive ventilation relates to the fact that we disrupt the body's natural defense mechanisms. We disrupt the larynx, we disrupt the vocal cords, we disrupt the normal clearance techniques and mechanisms, and so we increase the risk of our patients by intubating them of many, many complications, notwithstanding that of ventilator-associated pneumonia. So an endotracheal tube is not ideal, and we always teach to try and extubate the patient as fast as possible to reduce the risks of ventilator-associated pneumonia. I mentioned the issue, it preserves defense mechanisms. Non-invasive ventilation also allows eating, speaking, and expectoration. So patients are able to take the mask off. If it's a nasal one, they don't necessarily need to take it off. They can eat and speak and cough and splutter without the mask being come off. If the mask is a face mask one, obviously that needs to be removed. But if it's a nasal non-invasive ventilation mask, then that is much easier to do. We reduce nosocomial pneumonia and sinusitis. It's far more comfortable potentially and convenient for the patient. It's also easier to move around, and it can be administered outside of the intensive care unit. And we're going to talk a lot about that later on in this workshop, the role of non-invasive ventilation outside of a ICU service. So this is your classic patient with an ET tube in, a nasogastric tube in, clearly disrupting many barriers for the patient. This is one of our registrars who has kindly agreed to have a non-invasive ventilation, the nasal mask attached. I mean, you can obviously see how much happier he is, but he's probably just smiling for the photograph. But his mouth is free, and he is able to talk and be ventilated at the same time. So clearly, in the patients that it is indicated in, a much better option than putting an endotracheal tube down, given the disruption of those airway barriers. So how is it done? Well, the interface, as I said, normally is a nasal or a full face mask, and sometimes one can use a helmet. We're going to hear from Mr. Aref later in terms of the various ventilatory modes and ventilators, but most modern ventilators that you can use for invasive ventilation can be set up to use for non-invasive ventilation. And there are very many standalone, non-invasive, purpose-designed ventilators, particularly for home ventilation, that don't require all of the invasive ventilatory modes, but require a different time of computer setup, which can be set up for non-invasive ventilation. So your normal ventilator would work, but there are special ones, and we'll talk about the ventilatory modes a little bit later. So here you can see on the left the nasal mask, the full face mask, and then the potential full head helmet type setup that can be used for non-invasive ventilation. Here is a patient with you can see there, that doesn't look like a normal ventilator. That is a specific non-invasive ventilator that's being used on this patient. And this, for example, is a standard Vela, which we have as our ventilator in our ICU. And this particular one, if you look carefully in the top left-hand corner, is set for NPPV, which is non-invasive positive pressure ventilation. So this is a standard ventilation that I would use every day for a normal patient. I can switch to non-invasive by just choosing a different mode. And this is just one of many ICU ventilators that could have done that. And this is the one I said we have in our ICU. So what about the where? I've spoken about the what. Well, what about the where? Well, potentially you could even set up non-invasive ventilation in the emergency room. For the correct patient that comes in, there's no reason to transfer the patient to an ICU. You could do it there and then. It can be done in a high care or a high dependency unit. It doesn't necessarily need ICU because all the complications associated with endotracheal tube intubation are not there. And then Dr. Lee-Chiong is going to spend a fair amount of time chatting to us, and certainly in the discussion sections, about the possibilities of the non-invasive ventilation being used at home. And now clearly specific training, equipment is required and support. But with non-invasive ventilation, you have the possibility of ventilating a patient from the front door of the hospital all the way through to the front door of their house and even in their house. And there's some data to suggest that, particularly in Europe, that a large proportion of NIV is provided outside of the intensive care unit. However, it does require a major mindset shift. And certainly if the rest of Africa is anything like our hospital in Cape Town, you do require a large amount of thinking and discussion with the nursing staff, with other doctors, with hospital management, because the moment they hear ventilation, they're thinking ICU. And really this needs to be thought of a very helpful intervention that can be delivered outside of the intensive care unit. And I would suggest that its major role potentially is actually outside of the intensive care unit. But obviously that's going to depend on you and your hospital and the resources that you have available. So who could we use? The when and the why? Well, clearly patients that need ventilatory support, non-invasive ventilation or mechanical. Respiratory distress, the standard ones that you would recognize, shortness of breath, increased respiratory rate, hypoxemia, potentially hypercarbia. You do need to have the equipment available, and there needs to be an absence of contraindications, and I'm going to come back to that. I think that's very important because non-invasive ventilation is certainly not something that can be used on all patients. So who in reality are the ideal patients for non-invasive ventilation? Well, an exacerbation of COPD probably is your prototypical patient who just need assistance with ventilation to assist with blowing off their CO2 and respiratory support. You don't want to intubate very severe COPD patients if you can avoid it because of the complications. And so those patients are ideal and potentially can be stepped down from the high care ICU and potentially can go home on non-invasive ventilation with COPD. Acute pulmonary edema is also a very helpful, a very useful clinical scenario where NIV may be of value, because here really you just have excess alveolar water, and applying non-invasive positive pressure increases the transcapillary pressures and, for want of a simple term, drives the edema back into the lungs and is very useful for acute pulmonary edema. Things like acute bacterial pneumonia, COVID, severe ARDS and asthma probably are not ideal situations to use NIV in, because they generally require high FiO2s and high driving pressures and may be better suited to use invasive ventilation. And then in the more chronic, and this is now in the realm of home ventilation, patients with COPD, muscle weakness and paraplegia, where NIV takes on a completely different role outside of the acute setting in hospital. So who shouldn't get NIV? When should you not be thinking about it? Well, the patient that's had a cardiac or respiratory arrest, is not breathing on their own, or is requiring inotropic support, those patients need intubation to secure the airway because they're unable to secure the airway, and also they need mandatory ventilation, and so these patients do need to be on an invasive type modality. It's also important to remember that you are just applying a face mask to the patient. So people who have impaired level of consciousness, who are confused, who may be vomiting up blood, and you're worried about aspiration or are hemodynamically unstable, should also not be given NIV. These patients, if required, need invasive ventilation. If you've had facial surgery or trauma, you have upper airway obstruction, clearly a endotracheal tube is what is required to be able to ventilate the patient. Uncooperative, as I mentioned, patients who can't cough and clear the secretions. And then the last group are those that have bowel obstruction or upper GI surgery. These patients may well have stenting of their diaphragms. When you are on non-invasive ventilation, you may also be swallowing a fair amount of air. And so these patients are also not ideal because their abdominal distension or abdominal troubles may impact on your ability to ventilate the patient non-invasively. So it's certainly not a panacea for all, but is very useful in the patients whom it is indicated in. You do need to, and one would assume that if you have availability to mechanically ventilate patients, that you then would have availability to do non-invasive ventilation and not necessarily the other way around. But in patients who you are going to provide non-invasive ventilation to, it may fail for a multitude of reasons. One, they may have a respiratory arrest, they may have significant hemodynamic instability, or they may become increasingly confused or drowsy where they do not maintain their airways, they do not maintain the seal of the mask on their face, and those patients need to be intubated. Secondly, patients who are not responding. You have not been able to correct their blood gases or their respiratory rate starts to climb. These patients need to be promptly switched from a non-invasive strategy to an invasive strategy. So some final comments, and then I'm going to hand over back to our chair. In terms of non-invasive ventilation, I think one needs to think of it as a specific tool to do a specific job in specific patients. Very helpful to have the right spanner with the right nut to make sure that you can fix what needs to be fixed. You clearly need the skills and the equipment, but I think there's a lot of anxiety around this, and it's probably not as complicated as many people think. You do need, in my experience, a lot of buy-in from the nursing and administration. And I mentioned it earlier, when we hear the word ventilation, everyone thinks ICU, and really this is not the traditional mechanical ventilation with all its troubles. And so it should be, and I really think its unique niche place is outside of the ICU. You need to obviously be able to intubate and be able to do that fairly quickly. And the option of home ventilation or step-down ventilation is increasingly becoming available, certainly seen widely across Europe and potentially now increasing in Africa and the Middle East as well. And then finally, just to say, I think we need to change our mindset around non-invasive ventilation. I think this is a tool that we can use, and hopefully with this webinar and further discussions, we will equip people to consider this as an option. Dr. Mohamed, I'm going to stop there and hand back to you, and then we will take questions during the question time.
Thank you, Professor Richard, for your excellent talk, excellent comprehensive talk. And now I think it is the time to share with you my experience about the problem regarding the non-invasive ventilation and how could we solve it. Then we will open the questions regarding NIV and its usage with my dear Professor Richard. So, As I said before, I am a professor of chest disease, Cairo University, Respiratory Critical Care Medicine. This is the logo of my Faculty of Medicine, Cairo University, and this is the French hospital. Now it is an isolation hospital for COVID, and I am the medical director of the chest unit in the 7th floor department. First, I want to declare that the main difference between the intensivist and the pulmonologist is that intensivist be aggressive when you need, and the pulmonologist be non-invasive when the patient condition allows. This is a great difference between the intensivist and the pulmonologist. NIV looks like an airplane. If you cannot manipulate its buttons, you will be in an emergency situation, and you may get in a catastrophe you cannot deal with. Why there is lack in utilization of NIV? This is due to clinician skills and equipment selection and patient selection. So still NIV is lacking its usage, especially because of the physician lack the knowledge and also poor previous experience about the value and the end result of the NIV and regarding the training of the respiratory staff. So we are in need to create a training programs for respiratory therapists and the physician and the nurses and the other clinical staff with the aim of improving utilization rather than increasing utilization. And here, demonstrations that the nursing job is very difficult, and this is one of the major difficulties which non-invasive ventilation faces during its application. So the patient has many complications and many problems, and the ventilator has many problems, and you have to be aware about these problems, not to add the problem to the patient by ignorance or by lack of knowledge. So ideally, we want to optimize utilization regarding NIV rather than increasing utilization. So in order to optimize the utilization, you have to declare whether you have lung failure or pump failure. Lung failure means the failure of oxygenation rather than improving carbon dioxide remover, and the pump failure regarding improving carbon dioxide remover rather than improving oxygenation. So we have hypercapnic failure and hypoxemic failure, and the NIV has a successful rate in hypercapnic rather than hypoxemic, except in cardiogenic pulmonary edema, as Professor Richard mentioned in his talk. The main success for NIV is in good choice of the mask or the interface. The interface is the communication between the patient and the machine. So in mouth-to-mouth breathing, the mouth is the interface. In mechanical ventilation invasive, the endotracheal tube is the interface. In tracheostomy ventilation, the tracheostomy is the interface. Also, the face mask or the nasal mask or the nasal mask or the full face mask or the helmet mask is the interface. So choosing the best interface is the key success for NIV process. And we should mention that one size does not fit all. So each patient should customize his face mask according to his face configuration, not as socks, one size fits all. Okay. In the longer term setting, nasal masks are rated to be more comfortable, and other mask types cause skin problem less often. The main complications of NIV regarding air leak about 80 to 100%, and air pressure or flow related about 50%, and discomfort also about from 30 to 50%. So we are aiming to avoid endotracheal intubation with its complication, as my colleague Richard said, and we have to avoid this interface which cause inability to swallow and inability to get rid of the secretions from the bronchial tree with injury of the vocal cord. So shoot not to kill. This is the aim of the NIV. But we have to know very well the exclusion criteria if we have respiratory arrest, or if the patient unable to protect his airway, or if he has excessive secretion or hemodynamic instability or agitated, or have a respiratory distress, manifested by paradoxical breathing or upper airway obstruction or have any facial abnormality. So we have two types of mask, whether it is vented or non-vented. Vented mask means that he has an expiratory valve which can exhale the carbon dioxide, or non-vented mask which has double limb or one limb with exhalation valve also. So we have, whether it is vented or non-vented, to ensure that the patient is capable to get rid of carbon dioxide. Okay? Regarding the selection of the mask, we have to ensure that if it is vented and if it is non-vented, both of them should ensure that the patient is capable to get rid of carbon dioxide. So if you look to the elbow, if it is blue, this is non-vented mask, and if the elbow is clear, this is vented mask, and it is wrong to close this vented mask because you are going to make the patient suffocating. Major challenges for patient interfaces is to minimize the leak and maximize the comfort and limiting the dead space, and this should be achieved by customizing the mask. NIV again is effective in removal of carbon dioxide rather than improving oxygenation, except in cardiogenic pulmonary edema, which is acute care medical condition. So mask fitting is essential. We should customize the mask according to the face of our patient. One size does not fit all. Regarding some problems facing the mask, that there is air leak. Intentional air leak is intended, but the unintentional air leak, this should be compensated by the machine. So when you stop air leak, you are going to maximize the comfort for the patient and the function for the machine in order to avoid what's called air hanging, because if the patient to continue to escape the air beneath the mask, the machine will not sense that inspiration is terminated and will continue for giving tidal volume, what's called inspiratory hanging. So we have to tighten the mask, proper interface type, proper securing system, mask support ring, comfort flaps, tube adapter. We have to apply what's called the foam or hydrogel, chin strap, lip seal or mouth tapping. All of these measures reduce the air leak. Another type of mask is the helmet, which is not available in a much way in Egypt because it is expensive, but it causes arm edema because of its fixation below the arm. More comfortable, but first you have to ventilate the mask, then you are ventilating your patient and it needs a high flow, so it may cause headache and turbulence. Arm edema and deep venous thrombosis is the major side effects, but it can avoid what's called the claustrophobia, especially if you are using nasal face mask. So we have to choose our mask, whether it is oronasal or nasal or full face or helmet. And we have to position to optimize the position of our patient in a semi-sitting position, elevation of the trunk to decrease the work of breathing, okay, and to support the action of the accessory muscle of respiration. Regarding the complication, we have to optimize the care of the mask and prevent the skin damage and to obtain good sealing. And we may use sedation if the patient is agitated, but this is a debatable area, and to get rid of secretions and to give supplemental oxygen using the BiPAP or CPAP. So skin damage can occur giving the skin regular breaks and interface pressure, ideally every 2 to 4 hours, or rotating the mask, or using what's called silicone sheets or foam. It will minimize the pressure manifestation. Different self-cut hydrocolloid and gel sheets to be placed between the skin and the mask, or using the rotation of the mask in order to minimize the pressure sore. And using the 2-finger rule, which means that you are putting the 2 fingers between the headgear and to allow your finger to pass easily through it. This is the optimum pressure needed to fix your mask. Also, you have to give a good sealing to prevent the air leak by the two-finger rule, as I said. And we have to look the balance between the leak and mask fitting, not to increase the pressure and to avoid the formation of sore. So you are not in need to maximize stripping or strengthening of the headgear, but you have to optimize the mask usage. We have two subtypes of air leak: intentional air leak, which is intended if the mask is unvented, and we have another leak, which is unintentional mask leak, and the ventilator usually compensates for this external leak. And also we have another form of leak, which is called internal leak at the level of the stomach and the small intestine, okay? So what is the impact of the air leak? The impact of the air leak is the irritation of the eye, dryness of the eye, gastric distension, and noises. And if we minimize this air leak, the patient will feel more comfortable to the usage of the NIV. So if you have air leak small, you have to neglect. If it is significant, you have to tighten the mask. If the patient got comfortable, good job. If it is not, you have to recheck again. Regarding the secretion, you have to awake sedation. You use awake sedation without significant effects on respiratory drive. Some patients who remain very anxious or agitated, the mask, small dose of anxiolytic may be appropriate, but this is a debatable area. As I said before, you have pain and agitation and delirium, and this is a vicious circle responsible for failure of NIV, so you are in need to use analgesia or sedation. But in order to use analgesia and sedation, you have an ideal drug, which is short-acting, constant half-life, no accumulation in case of renal or liver failure, no decrease in respiratory drive or hemodynamic status, anxiolytic and analgesic properties. This is the ideal drug, which is actually not present. This drug doesn't exist. So you are justified to use the diazepam or lorazepam or midazolam or propofol or dexamethasone according to its value. Also, I wanted to declare that sedation is safe. Some say yes, some say no, and it is a matter of debate. Regarding the secretion, how can you get off the secretion? This is controversial. Unlike invasive ventilation, upper airway is not bypassed with non-invasive ventilation. With BiPAP ventilator, much of the delivered gas comes from the ambient air, and thus the same humidity that the patient would receive breathing without NIV. You have to assess for peak cough flow, and if it is low than 160, no functional cough, and you are in need to manipulate what's cough manual assist device or ventilator assist device. You can supply oxygen if your patient is hypoxemic through adapter underneath the mask you are using. One size does not fit all. I am sure it will fit. No hard feelings. Tighten the mask, air leak around the interface, tighten face mask. All of this should be solved in order for successful NIV process. Watch to the patient and listen to the ventilator. You have to monitor your patient, and you have to monitor the complication, and you have to monitor the signs of respiratory distress, whether there is abdominal paradox or accessory muscle of respiration working, or presence of over sign, which is intercostal indrawing. All of this signifies that your patient is not comfortable. So the right solution is to use the NIV, use it non-invasive, but intensive monitoring is needed. What is the difference now between the BiPAP and CPAP? BiPAP is continuous positive airway pressure with two different levels of pressure, while CPAP is continuous positive airway pressure. So we have two components in BiPAP, EPAP and IPAP. EPAP is responsible for oxygenation. So if you have a problem in oxygenation, you have increased EPAP, and IPAP is responsible for ventilation. So if you have a problem regarding carbon dioxide, you have increased the IPAP, and the difference between IPAP, EPAP is the pressure support or the pressure needed to unload the respiratory muscle and augment the tidal volume. Different usage of CPAP or BiPAP in obstructive sleep apnea, for example, we use CPAP, and it is of good value because it can splint the tongue, so it can create an open airway, and so it can prevent snoring and ensure good sleep by night. So you can improve this patient by what's called CPAP or O2 CPAP. So it is very effective in obstructive sleep apnea, not effective in central sleep apnea, which necessitate a respiratory center drive intact. You have to decrease, if you are using CPAP at the end of inspiration, the patient will expire facing a pressure. If you can minimize this pressure, you can use what's called C-flex or soft PAP or expiratory pressure relief, which allows the patient to exhale facing a pressure less than that he find during inspiration. Second application for NIV or BiPAP is the patient with obesity hypoventilation syndrome, and those patients usually have obstructive sleep apnea. So if the patient has severe obstructive sleep apnea and obesity hypoventilation syndrome, first you have to try CPAP, and if CPAP corrects the condition, continue with CPAP. If cannot, continue with non-invasive ventilation or the usage of BiPAP. One last indication of NIV is COPD, and the usage of BiPAP, and this is my last topic, is to improve better sleep and to improve better sputum clearance and to improve gas exchange without the need of endotracheal intubation. So to make a long story short, NIV in acute exacerbation chronic obstructive pulmonary disease, it prevents intubation and reduces the incidence of mortality. As you see, NIV is effective in reduction of mortality, and it is not a battle between the NIV and invasive mechanical ventilation. You have to choose and you have to clarify which patient will make benefit. So the indication of NIV in COPD is related to timing of the indication. Timing of the COPD failure. If it is early, NIV is great value. If it is late with disturbed conscious level and coma, I think NIV will fail and invasive ventilation will be the good choice. So invasive mechanical ventilation, if the patient has massive secretion or massive load or extensive respiratory muscle exhaustion or neurophysiologic disaster, the use of NIV shouldn't delay escalation to invasive mechanical ventilation when this is more appropriate, because if the patient has a respiratory arrest or severe respiratory distress or failure or contraindication to NIV, it is better to shift to invasive mechanical ventilation. And I think this is the time for opening of the questions. And let me start to direct my first question to my colleague, Professor Richard, to highlight the difference. Please, Professor Richard, if you are correcting a patient with acute pulmonary edema, what's your opinion regarding NIV versus CPAP, which is more beneficial for the patient from your point of view?
Thank you. Yeah, interesting question. I mean, I'm not up to date, certainly with the current research to answer that scientifically, but from a purely pragmatic point of view, in acute pulmonary edema, you are needing to increase the FiO2, so you're needing extra oxygen, and what you're needing is airway pressure. And so CPAP generally is much easier to use than non-invasive ventilation to set up. And so I guess my recommendation would be CPAP would be perfect, because all you're trying to do is push extra air pressure. It's basic physiology that we remember from first year medical school when we did physics. You're just wanting to apply pressure to the airways that drives the pulmonary edema back into the interstitium. And so I would opt for CPAP being just as easy, but if you have the skills and the availability for NIV, that would be great. I think the key point here is that intubating a patient that requires them to be sedated, to be initially paralyzed, to then intubate the patient for acute pulmonary edema really is a overkill in terms of resources. They may need it, but simple CPAP NIV should really get you very far without needing to do all of that other. And I've seen many patients, far too many patients, intubated for acute pulmonary edema, get given some furosemide, and a couple of hours later you then they're absolutely fine, and now you have to extubate them. You have complications of vocal cord trauma, poor intubation, etc., etc. And so I think that really is the classic example where NIV or CPAP would work beautifully.
Okay, thank you, Professor Richard. And I think the audience, do we have any questions from the audience? Okay. Now it is my great pleasure to introduce Mr. Aref Hajeer, Business Manager, Respiratory Care, Philips Middle East. Aref has worked for more than 10 years in ventilation, conducting in hospital training to healthcare professional on ventilation. Aref, the floor is yours.
Thank you, Dr. Mohamed. It's my pleasure to be here with you and with all the panelists. I would like to first to thank you for your great presentation. It was really informative, and thank Dr. Richard also for the same. Today, in my presentation, I will not talk about devices in general, because we have a lot of devices in the market, but I will talk about the innovative advanced technique that Philips has in their portfolio. We provided this kind of technologies to help people, either the clinical people to ventilate the patient or to give more comfort for the patient. And I like the slide which you showed, Dr. Mohamed, about the problems in ventilating patients, problem from the clinical side and problem from device side. And we have recognized this a long time ago, and we developed some technologies which can help in this regard. My agenda of today is going to be about the targeted patients that we aim to help with such technologies. The first technology that I will talk about is the Avaps. The other one is the automated airway management and the Avaps AE mode, and I will explain how you can get benefit from using those technologies. Let's start by the type of the diseases that we can cover, but it's not limited for, and we can help patients who is suffering from chronic obstructive pulmonary diseases, obesity hyperventilation syndrome patients, neuromuscular disease, restrictive and obstructive disorders, chest wall deformities, and trauma. And our technology is not only designed to be used at ICUs, but it can be used either in step downs or at home. So these technologies are available to continue improving the patient wherever he is. Let's start by the first technology, which is Avaps, and I will talk about it. Avaps is coming from average volume assured pressure support. So we take the first letter from each word and we put it as an Avaps. It's a hybrid ventilation mode. We call it like that because it combines the pressure and volume modes together in one category. And it automatically adapts the pressure support to the patient in order to guarantee that the tidal volume delivered to the patient is constant most of the time. And it's the first technology that can combine the pressure support and volume ventilation to manage the patient therapy effectively. And without Avaps, if the patient has a change in his tidal volume frequently, okay, the tidal volume which will be delivered to the patient, especially if using pressure modes of ventilation where you don't have any control on the tidal volume, it will be it will be not fixed all the time, and it will cause to fail the ventilation for the patient. Now, let's talk about the Avaps therapy in details. And as I said, it's an average volume assured pressure support. And in this case, you have to set three things. If we talk about let's take an example of BiPAP ST, which is a pressure mode where you have to set regularly, you set an IPAP, EPAP, and backup rate. And in this case, once you activate the Avaps feature, it's a feature here. Okay, you add it on, and then you will have an IPAP maximum, IPAP minimum, and then you have a fixed EPAP, and then you have a target tidal volume. The device will start on the minimal pressure all the time. So if the tidal volume of the patient is achieved, as we can see here in the graph, it's on the green line, it's achieved the target tidal volume. So the device is minimally giving the pressures as it continue to achieve the target tidal volume. Once something happened to the patient, the tidal volume of the patient drops down. And in this case, if you don't have the automatic Avaps, you need to increase the pressure for the patient manually. But with this feature, the device will automatically start to increase the IPAP to compensate the tidal volume and make it fixed or near to the target value. Then again, if the tidal volume maintains normally, the device will always go to the minimal pressure, okay, as long as the tidal volume is stabilized. And then again, if there is something happened which dropped the tidal volume, the device will start to increase the pressure automatically. And we have set something called Avaps rate or Avaps speed. And that range is from 0.5 to 5 centimeter H2O over 1 minute. So the change in the pressure, it's important to mention here, the change in the pressure is not breath by breath. So it is per minute. So that it will not be an aggressive increase in the pressure to maintain the tidal volume. So it gives the patient time to increase the pressure per minute, and it's as per your setting. So if you set it for example, on 5 centimeter H2O, that will take 1 minute to increase the pressure from the IPAP minimum to another 5 centimeter H2O within 1 minute. The benefits of using the Avaps, it's maintaining the tidal volume while using pressure mode, and this is an important one because if you use the pressure mode alone, you don't have any control on the tidal volume. Also, it can help to improve the comfort while guaranteeing the safety of the ventilation. How to set the Avaps? Okay, normally we recommend this recommendation for setting the Avaps. Normally you start with EPAP of 4. Okay, if the patient don't have any overlap syndrome or with sleep apnea or any sleep apnea syndrome, then the EPAP needs to be adjusted or titrated before you put the device or the Avaps feature on. So if the patient have no sleep apnea syndrome, then we start with 4. If not, if the patient have a sleep apnea, then the patient need to be titrated in the sleep lab, and then the minimum pressure will be his EPAP at that time. IPAP minimum, we set it as EPAP plus 4 centimeter H2O. Depend on the disease, you can increase it more if you feel that you need more pressure to start with. And the IPAP maximum, we always recommend to set it 10 centimeter H2O above the IPAP minimum. Depending on the disease, you can increase it more as long as you need to achieve the tidal volume. Tidal volume, we use the ideal body weight formula to calculate the tidal volume, and mainly we calculate it as 8 ml per kg of the ideal body weight. Again, it's just to remind you, Avaps can be a therapy in some devices in some Philips devices like the ICU ventilator V60 or whatever, and it can be a therapy option. Okay, when you use it for let's say long-term ventilated patients and home devices, and it can be used with pressure modes of ventilation like S mode, ST, pressure control, and time mode. And the key message that or the takeaway message that I want to emphasize on, which is the Avaps is giving the right pressure at the right time for the patient. Next one is the automated airway management, and here we, if you remember in the Avaps, we talked about IPAP maximum, IPAP minimum, and now we will talk about the EPAP itself if the patient has an overlap syndrome like obstructive obesity hyperventilation syndrome patients. And according to studies, we found that in some studies here, 29 to 40% of COPD patients, they have obstructive sleep apnea. 90% of obesity hyperventilation syndrome patients, they have obstructive sleep apnea. 21% of multiple sclerosis patients, they have obstructive sleep apnea. And this is the source of the data that we provided here. So in this situation, if you use the Avaps feature, you will guarantee the tidal volume of the patient, but you need something still to maintain the patient airway open. So that's we add the feature, which is automated airway management, and it can monitor the upper airway of the patient. Whenever the device will feel that there is a closure or airway obstruction, then the device will start to increase the EPAP within a range you put for the patient. So it's a feature. And once you activate it on, it will give you the facility to add EPAP minimum and EPAP maximum for the patient. And then the device will start with minimum EPAP. Whenever the device feels that there is an airway obstruction, the device starts to increase the EPAP automatically without any manual adjustments. The setting, only you set minimum and maximum EPAP, as I mentioned, and it's one button to do the automation, and it's contraindicated for pediatric use. This is according to what we tested the device with. Last but not least, Avaps AE as a mode. So think about if we can combine these two features, the Avaps and the automated airway management, and combine them in one mode of ventilation, non-invasive ventilation. And this is what we did in Philips, and this is what we created, how we created the Avaps mode. It has three main features: the auto pressure support by using the Avaps, which maintain the target tidal volume for the patient. The second thing, the auto EPAP, we added it in the same mode, so it will help to maintain the patient airway open. And you can also use the auto backup rate feature, which the device will keep calculating the backup, the respiratory rate for the patient every day, and according to his respiratory rate, it will change the backup rate according to the patient need, because we all know that the patient situation is not fixed every day. So there is a changes in his respiration or in his tidal volume or in his lungs status. So it's good to have all of these features automatically in one mode, non-invasive mode, and it will help you to just to put the patient on the device and leave him, and the device can take care of him, whatever the changes he has. So as I mentioned before, and as I mentioned the previous studies, I will not go for them anymore, but it's good to remind you about the 90% of the obesity hyperventilation syndrome. They have obstructive sleep apnea, and maintaining their airway is an additional tool to deliver the correct level of ventilation for each patient. And how it works, this is the slide or the graph that I want to show you. Here we are talking about the pressure support maximum and minimum. The pressure support will be changed because we are changing the IPAP and the EPAP. And we all know that pressure support means the difference between the IPAP and the EPAP. So if we minus IPAP, if we take IPAP minus EPAP, it equals to the pressure support. And here we have the EPAP minimum, and the EPAP maximum. We have the target tidal volume, and we have extra thing here, which is the resistance which indicate the airway obstruction of the patient. So in the first example here on the graph, we see that everything is normal. the tidal volume that delivered to the patient is within the limit that within the target that we put for, and the resistance is okay. There is no airway obstruction. Then suddenly the device will find the drop in tidal volume, for example, and then we expect from the device to start to increase the IPAP at that time, because there is no increase in the resistance. And this is what the device did. It kept the EPAP on the minimum, minimal value, and it increased the IPAP only. Then the tidal volume of the patient, it went back to normal. Then the device will start to go to the minimal pressures, as I mentioned before. And in the other example now, you will see that there is an increase in the resistance and a drop in the tidal volume at the same time. So the device increased the IPAP automatically and increased the EPAP also automatically until it solved the problem. So if the airway obstruction is resolved and the tidal volume is again maintained, then the device will go back and will drop the pressure to the normal values. So this is my presentations. I will leave the questions after Dr. Teofilo, so we can have the questions together after the other presentation. This is from my side, Dr. Mohamed. Thank you very much for giving us this chance.
Thanks, Mr. Aref, for this illustrative talk about the physiologic effects of the new technology regarding the delivery of the pressure modes targeting specific volumes with the character of the pressure, considering the two variable parameters which are changeable every now and then, the resistance and the compliance, and in addition to that, the airway patency, which changes during the night and changes during the day, and hence the value of Avaps AE, auto EPAP.
Yes.
Thank you very much, and I have a question regarding my talk. When you are using NIV through a tracheostomy, are you going to use a single limb or dual limb? If you are using BiPAP or NIV in the intensive care using endotracheal tube or tracheostomy tube, it's better to use two limbs. If you used single limb, you have to ensure expiratory valve, swivel valve, to ensure exhalation. But it's better to use two limbs, one for the in and one for the out. Okay, I think this is the time to introduce my dear colleague, Teolo Lee-Chiong. He is a professor of medicine, Division of Pulmonary and Critical Care Medicine, School of Medicine, University of Colorado, Denver, and he will speak about home non-invasive ventilation for different respiratory disorders, how to avoid hypercapnic respiratory failure. Professor Teolo, the floor is yours.
Thank you for having me. I just want to confirm that you can hear me and see my slide.
Yes, we can hear you and we can see your slides.
Thank you.
Okay.
Again, thank you for having me. My goal today is very simple. It is how to help you start NIV today if you need to use it for your patients. Before I start, let me qualify some statements. Whenever you have a patient with respiratory failure that you think you might need to have ventilatory support, either invasively or non-invasively, it is important to consider two things: how to start and a strategy to liberate the patient from mechanical ventilation. It's also important to have clear objectives in order to communicate clearly with your team on what needs to be achieved for each unique patient. When we talk about respiration, we have to also realize that the lung is not only linked to the heart and the circulatory system to provide exchange of oxygen and CO2, It is also linked to the kidney and renal function for exchange of acid-base. So when we talk about the use of ventilatory support, it is important and essential to remember the two functions of respiration in gas exchange and in acid-base balance. So selecting the right patient is important, but equally important is selecting the right therapy. Then finally, selecting the right management. And I'll try to go through all of this today. Whether you have a patient with respiratory failure due to COPD, or obesity hyperventilation syndrome, or neuromuscular disorders, often hyperventilation starts as an episodic nocturnal event. Allow me to explain this. So if you plot the airflow and your level of CO2, in a person with stable metabolism, they will develop a pattern of breathing that will maintain CO2 levels at a very narrow limit of normal. Whenever there is hypopnea, you will have CO2 loading. Clearly, if you have anapnea, or if the event is longer, then you have greater CO2 loading. These events are usually followed by a period of hyperventilation where you have CO2 unloading. So if you were to plot in a diagram the apnea-hypopnea duration and the chronic wake CO2 levels, you will see that the longer duration of the event, the higher the levels of CO2. Similarly, if you plot the post-event ventilation to that of the CO2 level, then you will see the reverse, is that the more robust the ventilatory response, the lower your CO2 levels would be. As the patient's disease progresses, you will have another problem, another challenge to contend with, and that is the inadequate response to these events. This may be due to altered lung mechanics, ventilation perfusion abnormalities, reduced chemosensitivity, or even suppression of respiratory drive. For instance, in somebody with obesity, you may have elements of leptin resistance. The person may have increased mechanical loading and weaker respiratory muscles, or they may have comorbid sleep apnea, all of which by themselves can lead to hypoventilation, but can also work together to lead to worsening hypercapnia. Let's look at obesity hyperventilation briefly. A person with obesity may or may not have hypoventilation. However, in both of these groups, there's increased CO2 production. Also, in both of these groups, there's often an increase in the respiratory rate. Specifically, in those patients with obesity but without hypoventilation, you will see that the tidal volume doesn't change, so the increase in respiratory rate will lead to an increase in minute ventilation that would compensate for the increase in CO2 production, therefore maintaining a normal level of CO2. In contrast, in patients with obesity and hypoventilation, there is a reduction in tidal volume. This leads to a reduction in minute ventilation that, coupled with the increase in CO2 production, eventually leads to hypercapnia. So therefore, a feature of obesity with hypoventilation is the reduction in tidal volume, causing an increase in CO2 levels. Then finally, in advanced cases of COPD, obesity hyperventilation, or neuromuscular disorders, there's impaired ventilatory control. As I mentioned earlier, whenever you have respiratory acidosis with an increase in CO2 levels, there's a compensatory mechanism to increase bicarbonate reabsorption by your kidneys. This is good because it maintains acid-base balance. However, this is done at the expense of reducing further your ventilatory response. In other words, if you look at your awake levels of CO2 and awake levels of bicarbonate, in a patient with normal lung and renal function, you will have normal levels of both. In a patient with either pulmonary or renal impairment, you will have higher levels of both. And in a patient with both kidneys and lungs failing, then you will have highest levels of both CO2 and bicarbonate. So you have a person whose hypercapnia starts as an abnormal event, eventually leading to abnormal response, and finally culminating in abnormal control. So you have CO2 levels that are high during parts of the night, the entire night, then finally both night and daytime. So what's a therapy? When we talk about ventilation, whether it be invasive or non-invasive, there are two types of devices, a pressure control and a volume control. A pressure control is any device that's designed to provide a fixed pressure with every breath. However, because of differences in lung compliance and airway resistance, the volume delivered is variable and often unpredictable. In contrast, in volume control, the device is designed to provide a fixed volume. But for the same reasons of changes in compliance and airway resistance, the pressure is variable. We will talk today mostly on pressure control with non-invasive ventilation. But those of you who are familiar with the ICU ventilators, there is a correlation between some modes in volume control and others in pressure control. For instance, if you're familiar with assist control in your ICU ventilators, then you can think of the BiPAP spontaneous time mode as your pressure control correlate of that device. But we're going to talk today mostly on the bi-level devices, the spontaneous time, the volume assured pressure support, and the volume assured pressure support automatic EPAP. The challenge we face with a patient with respiratory failure are multiple. They may have hypoxia, they may have comorbid sleep apnea, and of course, they are hyperventilating. And whenever you see these challenges, you have to decide which one to address first. My bias is that the upper airway obstruction should be corrected first, because without doing that, we cannot ventilate. And when ventilation is insufficient, we cannot achieve a correction of your hypoxia. And how do we address all of this? Well, for upper airway obstruction, we can use a CPAP or the EPAP of a bilevel. EPAP is a lower pressure of the bilevel device. For hyperventilation, we can decide to increase the rate if it's too low, or we can add the pressure support, the difference between the IPAP and the EPAP of a bilevel. And for hypoxia, in addition to providing oxygen therapy, we can change the rate if it's low. We can add EPAP to increase lung capacity or provide pressure support to augment tidal volume. So what we can do today with our devices is simply we can change the EPAP, CPAP. We could alter the pressure support. And of course, we can always add a rate. And with the three in mind, we have the first generation bi-level devices, the second generation volume assured purge support, and the third generation volume assured purge support with automatic EPAP. And what we have done is change from a BiPAP where you have to manually enter your EPAP, CPAP, pressure support, and rate to a second device where we have automated the pressure support. And finally, to the third generation, we have automated all three. Allow me to explain. So this is your first generation bi-level device. If you work in the home, then a BiPAP 10/4 is usually thought of as an IPAP of 10 and an EPAP of 4. However, if you're more familiar in the hospital environment, you can also see the same BiPAP 10/4 described as a PEEP of 4 with a pressure support of 6. So whenever you see a person with low tidal volume, you observe them and they have very shallow breathing, or they are hypoxic, or have high levels of CO2, then you could increase the pressure support accordingly until such time that you can correct the low tidal volume, low oxygen, or high CO2. You could also change the mode from a spontaneous mode to a spontaneous time mode. What do I mean by that? A BiPAP spontaneous mode, all the breaths are generated by the patient. So the duration of interval between breaths can be variable. In this example, it can range from 5 seconds between the first and the second breath, 4 seconds between the second and the third breath, and 8 seconds between the third and the fourth breath. The BiPAP ST mode provides a backup so that if no spontaneous breath occurs within that period of time, then the machine will provide a machine-generated breath. In this example, you have a backup rate that is set to provide a breath within 6 seconds. So in the example here between the second and the third breath, since there was no spontaneous breath, the machine gave a backup rate. In the second and third generation, we have automated some of the features. This was discussed earlier by Aref. So this is an example of your second generation volume assured pressure support. You still have to manually enter your EPAP in blue in the foreground, but the machine will automatically alter the IPAP, therefore changing the pressure support whenever the tidal volume drops below your target levels. And we will discuss this in more detail in the next few slides. In the third generation bi-level device, in addition to the automatic pressure support titration, you also have a way to measure upper airway resistance, in this example in red, and have the ability to change your EPAP to maintain upper airway patency in blue. There's also a way to measure your baseline respiratory rate, and with that automatically provide a rate whenever the patient's spontaneous breathing goes below that target. So management. These are your choices whenever you have a ventilator to work with. And they seem confusing, but allow me to break it down to simplify it. So what are the modes? These are the modes available, but the ones that are probably used most often are the ones you already know. Your BiPAP S mode, your BiPAP spontaneous tide mode, and I've discussed your volume assured pressure support automatic EPAP mode. There's also another pressure mode that you need to understand. It's called the pressure control, and I'll try to discuss that later. So the modes are familiar to you. The tidal volume ranges from 50 ml to 2 liters. And we often talk about a target tidal volume. And for most devices, it is about 6 to 8 ml per ideal body weight kilogram. And why is this important? because somebody who weighs 200 kilograms does not have twice the size of the lung as another person who weighs 100 kilograms. So it is ideal body weight. And the 6 to 8 ml kilogram ideal body weight target is also physiologic. If you look at, for instance, a whale, a large mammal such as the whale or an elephant, or a small mammal such as the rat, all of this, along with humans, have the same 6 to 8 ml kilogram ideal body weight tidal volume. So this can be used as your initial target. And then you can change the supporting pressures based on patient comfort. So if they say, well, the pressure is insufficient and I am struggling to breathe in, then by all means, you can increase the target tidal volume to improve patient comfort. On the other hand, if the patient complains that it is too excessive, then you might also consider lowering the target tidal volume temporarily to provide comfort. Finally, it's important to talk to the physician. The patient may have unique characteristics. He or she may have had a pneumonectomy or large bullae with recurrent pneumothoraces that will be important to change your target tidal volume. The Avaps rate has been discussed earlier. It is nothing more than a change in your inspiratory pressure. And for most of our patients, I would suggest that you put a default setting of 5 cm water per minute. So this is your Avaps rate, how quickly it changes to reach your target tidal volume. Then you have your rates, you're all familiar with them. Respiratory rate can either be manually entered between 0 to 60 breaths per minute or automatic. And I would like you to consider perhaps using an automatic backup rate because of its multiple benefits. One, the backup rate will not exceed the patient's resting respiratory rate. Secondly, it might improve ventilator patient synchrony. It would allow the patient to terminate a machine breath if they decide to breathe out, and it allows the patients to also exhale by enabling the machine to delay its delivered breath. The ramp is also a feature. Unlike sleep apnea patients where ramp is often used, I have found the ramp feature less helpful in NIV patient use. Trigger, there are many types of trigger. Again, if I will allow you to consider using an automatic trigger, meaning that the automatic trigger will trigger the cycle and the triggering, even in the presence of leak. And more importantly, it will adapt the trigger and the cycling as the disease progresses. You then have the rise time between 1 to 6. Rise time is the time it takes from the patient to go from EPAP to an IPAP. And there's a range from 1 to 5 to 6. So 1 there, you see that the rise time is faster. And at 6 there, the rise time is slower. For most patients, a common default setting is a 3. So you could have 2 ways to determine this. One is you can titrate the patient, meaning you can ready the patient, you can aim the settings and then start the device. Or you could use default settings and then change it based on your needs for each particular patient. So for instance, you may choose a primary mode, Avaps AE, with the default settings as stated. You can also use a different mode from the evening when the patient is asleep versus in the morning when they're awake. You could plan for a secondary mode, such as a mouthpiece ventilation. Why? Because in the chronic setting, patients are able sometimes to leave the bed and bedroom. So when you have a mouthpiece ventilation, this provides an intermittent support rather than continuous. The trigger is a kiss. So you put, the patient would turn the head and either touch his or her lips or tongue to the trigger, and the breath will be delivered. And then finally, the disconnect alarm, so the alarm for disconnect will be disabled. So how do we use this? So for instance, if you use default settings, you can then change it for each patient's unique needs. In a COPD patient, when there is expiratory flow limitation or what we call air trapping, it may be important to increase your EPAP to not simply correct for just the airway obstruction, but also allow for that EPAP to correct for the auto-PEEP. A rise time may also be important because patients with COPD tend to breathe in fast and breathe out slowly. So in a person with COPD, you might consider changing the rise time from a 3 perhaps to a faster rise time of about a 2. In obesity hyperventilation, in contrast, because of the common comorbidity of sleep apnea, you may want to adjust your pressure port and EPAP to account for the presence of sleep apnea. You can also change the rise time. Unlike COPD, when they breathe fast and breathe out slow, in OHS, because of the weight of the loaded chest tissue, as well as respiratory muscle weakness, they tend to breathe in slowly and breathe out slowly too. So you might consider changing the rise time to perhaps a 3 to that of a 5. Finally, in neuromuscular disorders, they have difficulty maintaining inspiration. So if you see, for instance, with the BiPAP ST mode in a person with neuromuscular disorder, you will see that the inspiratory time differs from breath to breath to breath. And a pressure control mode will tend to stabilize that by maintaining an augmented breath in order to maintain a more uniform inspiratory time with each breath. Once you have established your default settings, then it's time to adjust the device for both patient comfort and efficacy. For instance, if you have established a target tidal volume and you see that the average tidal volume is very close to your target tidal volume, then you may say, well, is the average IPAP within 5 of your IPAP maximum? Meaning, is your IPAP very close to your IPAP maximum? If that's the case, you may either increase the IPAP maximum to allow more reserve or continue to monitor. However, if your target tidal volume minus your average tidal volume is greater than 100 ml, meaning that your average tidal volume is not reaching your target, then you might consider increasing your IPAP maximum, increasing your maximum pressure, or checking for mass leaks. There's also a rather common phenomenon. We call that air hunger, where the patient may have a low IPAP, but they breathe in, where they have a very high tidal volume. Okay. When this is seen, then consider increasing your target tidal volume. Let's go now on to the trigger. You can also change the trigger to be less sensitive or more sensitive. So for instance, if the patient's trigger breath is about 80% and there's no excessive trigger, then you can continue to monitor. Finally, with pressure, the patient complains of too much pressure, you can have some options, increasing the rise time, decreasing the IPAP minimum, or decreasing your target tidal volume. When there's not enough air, then you can do the opposite. Decrease the rise time, increase your IPAP maximum, or increase your target tidal volume. Then finally, If a patient describes feeling a flutter, there's a vibration that they feel. Some of you may have noticed this if you were driving a car and somebody opens a window and all the other windows are closed, then the car will start to vibrate. This is something that the patient may feel whenever they're placed on NIV. Inform the patient that this is common, and when this happens, a quick temporary fix is to simply set your EPAP and EPAP mean, collapse your EPAP to the EPAP mean, and this will often manage that. So allow me to just end by saying abnormal event, abnormal response, abnormal control. Hypercapnia may occur during parts of the night, entire night, or during the day as well. And therefore, your treatment has to go from reactive, escalated to responsive, and finally, in severe cases, you have the target therapy and have multiple modes, one for the night, one for the daytime, one for activity, and perhaps even one for exacerbations if it's common. Allow me to end with a few slides on outcomes. For COPD, we often use the non-invasive ventilation in the hospital for acute respiratory failure. And for these patients, the data is quite clear. For instance, used properly in the right setting, NIV used for hypercapnic acute respiratory failure for COPD will reduce intubation, reduce nosocomial pneumonia, and reduce mortality. Thank you. Thank you for having me.
Did you finish, Professor Teolo?
How much more time do I have?
Okay, thank you for your excellent illustration talk. And I think I have many questions. The first, can we use synchronized intermittent mandatory ventilation mode as non-invasive ventilation mode?
Yes, so many of the devices do have a pulse control SIMV feature. If you're more familiar with SIMV, then that may be a feature that you might want to choose. Again, sometimes it is our own experience, our team's training that would allow us to choose what's best for the patient.
Okay, thank you. And I have a question for Professor, for Mr. Aref. Can Avaps be used with invasive ventilation, Mr. Aref?
Yes, doctor. Yes, actually, Avaps can be used invasive and non-invasive. So the feature itself, it can help to maintain the tidal volume for the patient, either using the non-invasive method or by the tracheostomy tube or the endotracheal tube. It will help to maintain the tidal volume. On the other side, the Avaps AE as a mode, okay, they cannot use it invasively, okay, because it's need an airway, okay, to increase and decrease the automated the EVAP itself. That will not work with
this is an important issue because regarding AVAPs, O2 EPAP, you are using different EPAP because there is difference in patency of the airway during the day and during the night. If you insert the endotracheal tube, it will be invasive ventilation and the patency of the airway will not change at all. So Avaps AE will not work. The patient will gain no benefit from Avaps AE.
If they use it invasively.
True.
Yes, if you
Yeah.
use the invasive. Okay.
Exactly.
I have another question. I think it is for me. What is the percentage of oxygen used? Normal air or anything up to pure oxygen? I think the main value of ventilation is to remove carbon dioxide. And this is a process of ventilation, removing of carbon dioxide. But if your patient is hypoxemic, you may add external oxygen through an adapter, which could be passed underneath the mask, if it is oronasal or oral mask, through a certain adapter using the selected desired level of FiO2 you want to deliver. But you have to be careful that NIV is successful in hypercapnic respiratory failure and in just only early cases of hypoxemic respiratory failure. For example, if you have a patient with mild ARDS, NIV may work very good if you introduce the early for mild case, but in severe or moderate to severe cases, it will fail, and it is very useful to start invasively rather than non-invasively. If you have a pneumonia with mild hypoxia, you may try non-invasive ventilation, but if the patient is presenting with severe hypoxemia, you have to shift to invasive mechanical ventilation from the start. Also, if you have a COPD early, you may indicate for him NIV, but if this patient came with a decompensated pH and very low pH and high carbon dioxide with disturbed conscious level and coma and respiratory distress, it is better to shift to invasive mechanical ventilation. So it is not sufficient for you to have a diagnosis that the patient has COPD. You have to categorize which patient is mild, moderate, severe, severe to critical COPD. So you are going to maximize the value of NIV or the value of invasive mechanical ventilation. My question to Professor Richard, could you comment on the difference between hypoxemic and hypercapnic respiratory failure regarding the wide usage application of NIV, please?
Yeah, I mean, I think the issue of hypoxemia, again, it depends on the mechanism of hypoxemia. So things like pneumonia, where you have shunting, you require a high FiO2 to compensate for that. And so NIV is not ideal to generate that. For something like COVID pneumonia, we require high driving pressures. So often we have patients sitting up with 15, even 20 millimeters of centimeters of PEEP. We've got high inspiratory pressures, and NIV is not suitable because you can't get a decent seal on a patient's face without causing all the trauma that you so eloquently described. And so trying to put a face mask on a patient and ventilate them with those pressures is impossible. So, for those hypoxemic events, it's really where hypoxemia is profound, NIV is likely to fail. In a patient with COPD, it's not necessarily always a primary hypoxemic event. It's that they don't get enough respiratory effort, their respiratory drive is compromised, and so additional support that enables them to get a decent tidal volume, which enables them to increase their minute ventilation, will get rid of their CO2. So NIV that provides that little bit of extra support that reduces the work of breathing, so they're not working as hard, NIV works beautifully. I mean, the contrast, I think, is asthma, where the issue there is tight airways. And so for asthmatic patients, I've seen it too many times in our emergency unit. The casualty officer says, I tried the patient on CPAP and it didn't work. Well, CPAP's like just putting a hairdryer in your face and trying to get someone to breathe on it. Whereas NIV, that hairdryer is switching on and switching off every time you breathe in and breathe out, whereas CPAP is just blowing in your face. So I think we can get into trouble by getting too fancy and not understanding basic physiology. But I think once you understand basic respiratory physiology and can work out what you're trying to do, then the ventilation becomes that much easier. And one last comment, seeing you got me on the mic here. I think, as Dr. Lee-Chiong mentioned, we get comfortable and we get familiar with settings. And we've seen this in the COVID ICU. I mean, we've ventilated far too many patients. Some of us are very comfortable with a SIMV, a mandatory ventilation, synchronized. Some of us are more comfortable with a pressure support based. And then you get, all these different acronyms that unfortunately different companies mean different things. And a PSIV on a Vila is a APRV on a Draeger, which is a SQZW something on another one. And so I think we need to try and get away from the acronyms because they mean something, but also to understand what we are doing. What is the machine actually doing when I set this? And to not overcomplicate things for us. So as we learn, you start on the simple. And as you get more experienced, you can then start doing things. But you can get so confused by a machine that you think is doing one thing, but actually the machine's doing something else because some clever guy somewhere decided that you didn't know what it was doing. And those are very dangerous because you think it's doing something and that's what you're trying to do, but the machine thinks you're an idiot and is doing something else and you get nowhere. So I think we need to be understand what we are doing and what the machine is doing, and is that the best thing for the patient. And that does, as we've all said, unfortunately take a little bit of training and a little bit of experience, but I think probably less than all of us think, and so it shouldn't be something to be feared.
Okay. Thank you, Professor Richard. My question to Professor Teolo Lee regarding ventilating an obstructed patient. If you have airway obstruction, are you going to make certain changes regarding the inspiratory time or rising time or the rate of pressurization? Regarding the expiratory trigger sensitivity, are you going to make certain maneuvers which shorten inspiration or prolonging expiration so as to decrease the air leak and to improve the synchrony of the patient, or it will not differ from the ventilation point of view regarding these parameters to be changed or not?
That's a very good question. Sometimes we tend to oversimplify, but other times we tend to overcomplicate, right? So it's nice to have a sort of a balanced view of this, knowing that there are some goals we can achieve quickly and some goals that may take a longer time to get to. So I think one of the priorities that when we put somebody on a ventilator, invasively or non-invasively, is to discuss with the patient and their family what the goals are, right? Secondly, is to allow the patient to get used to the treatment, the therapy. Sometimes there's fear, sometimes there is discomfort, sometimes it's just the lack of knowledge that prevents them from accepting the therapy as well as others did. Then finally, once you have achieved that, then there are other things that are very important to understand too, is that certain settings may enable or impair communication, may affect nutrition and feeding, may cause skin breakdown, right? So these are the things that we need to address as well. So yes, it would be so easy and so simple to just put everybody on the same mass, same pressure, and have the same protocol. But like you said earlier, the patient There's no one size fits all. And yes, the nuances, the complexity of therapy then comes into place. And what we start with science then really has to have some art in it as well.
Okay, thank you. I have one more question. I think it is for me. Non-vented mask with whisper swivel can be used with single ventilator, or it is unsafe for the patient. The main issue is to ensure for the patient to get out carbon dioxide. Carbon dioxide removal is the main issue, whether you are using single limb or dual limb. But in case of ICU ventilator, you have to use dual limb, one for in and one for out, and to collect what's exhaled from the patient and to be interpreted by the ventilator to detect whether there is air leak or not. But it is safe to use non-vented mask so long as you are assuring that the patient will exhale using what's called whisper swivel, or if you are using a vented mask with external leak, both of them working outside the ICU without any fear. And in addition to that, we have to obtain what's called asphyxiant valve. In case of power off, the patient are not going to suffocate. My question to Professor Richard, if you have a patient with ventilatory failure, would you prefer to initiate volume controlled ventilation or pressure controlled ventilation?
So, talking about mechanical ventilation rather than non-invasive, the answer is it depends.
Yes.
I am, over my last 18 months working almost full-time in the intensive care unit in COVID, I've become far more comfortable with pressure modes. And in my severe ARDS patients, I currently prefer a pressure mode. I don't like pressure modes in my obstructive airways patients, particularly the asthmatics. And the reason for that is that if you've got a very tight asthmatic on a pressure mode, often you need to dial up the pressure. And when the asthma settles and your respiratory therapist or your nurse next to the bed doesn't notice it, you can cause major problems. So I tend to prefer a volume-based mode for my obstructive airways patients. But my default is always, when I'm in trouble, I go back to what I know and I start back with volume control SIMV. I get my 400 mils in, or my 500 mils, my 6 mils per kilogram. I dial in my PEEP and I see where I go. And from there, then, and I think Dr. Lee-Chiong is absolutely correct, then unfortunately the art comes in. And I haven't yet been able to teach my surgical registrars over the phone how to tweak a ventilator. That's when I need to come in from home and sit there with the ventilator and see what it's doing and make those adjustments. And then I think you change. You change to a pressure mode and you see what you get. If you're not working with that, you come back to something else and you find the one that suits the patient the best in the acute setting, achieves what you want to achieve with the least trauma or potential damage to the patient. But ventilation is a dark art. It requires all sorts of magic and things going on in your head to set the patient. And I've got colleagues who can come to a ventilator and twiddle a few knobs and doop, the patient's perfect. So it does require experience and that art of fiddling.
Okay, thank you. One more question. I noticed.
Dr. Mohamed, I want to add one comment on the question that you answered a while ago on the single limb circuit using the whisper swivel. As we faced a lot of during the COVID pandemic in the last year, we faced a lot of questions regarding this. If the patient is infected and he has, for example, COVID or any types of viruses,
Contamination.
Contamination, exactly. It is risky for the clinical users who's around the patient that they will get infected from because the whisper swivel will create the air outside. And That was because of the lack of ventilators available and the huge number of patients who need ventilators. So if you allow me just to share my screen, we have came with one solution to solve this, and I can show it here. So we came with this solution actually, if the patient is using it. So what we did between the interface here and the whisper swivel, which is here, we did the bacterial viral filter. This will help to protect the air, the exhaled air which coming from the patient to be filtered before it goes to the room air. And it was a really good solution, and it decreased the danger of having the patient exhaled air in the room air. I don't know if this will add a value, but I think it's good to mention.
Okay, thank you. Nice. I have one last more question. I noticed that there is no pressure triggering in the NIV devices, mainly flow and auto track types of triggering. Why? May I answer this question? I think the ventilator can be triggered either by the patient or by time as the machine. The machine may trigger the press itself. But if we are talking about the patient may trigger the machine either by flow or by negative pressure. What is more convenient for the patient is to trigger the machine by flow. The machine will sense the effort of the patient, whatever it is minimal, and it will supply him with the tidal volume with the minimal effort, taking into consideration not to lower the trigger sensitivity less than 3 centimeter water or less than 3 flow, as the patient may develop with the machine what's called auto triggering. The machine will be very sensitive to the heart pump, to the secretion in the airways, to the fluids in the tubes. So it may create what's called auto triggering. So you are in between to optimize the triggering, not to be very hard for the patient to trigger it, and not too low to be too low to create what's called auto triggering. Pressure is more hard for the patient to trigger in comparison to flow. Flow is more comfortable for the patient, and the machine will sense any effort triggered by the patient. I think if there is anyone has another comment, welcome. Okay. So, Mr. Aref, I think we just finished all the questions submitted to us, and I have to remind our audience that they have a survey that kindly you are requested to fulfill this survey to be submitted to Philips to improve the next workshops. And I think if you have a word, Mr. Aref, for the audience and for the speakers.
Yeah, it's my pleasure to take this chance to thank you, Prof. Mohamed, for chairing this webinar, and let me also thank Dr. Richard, Prof. Richard, Prof. Teofilo, and the Philips teams who did all the arrangement for this. Silva, Caio, Fiona, and Njabulo, if I mentioned the name right. Also, just here we have the contact details of our sales team in Africa. Please feel free to send any question for them. The contact details are here. And I would like also to take this chance also to thank the attendees for attending this webinar. And we wish also in the future to have more, let's say, webinars to increase the awareness about non-invasive or any other things that we can help to add benefits for patients or for the clinicians. Thank you again very much, and I will leave it for Caio if he like to say something.
No, I think Aref, you have covered it all. So thank you, Professor Mohamed. Thank you, Professor Richard and Professor Teofilo. I really appreciate it. Very good slides and very good information. A lot of new things which I've learned today from those slides. So thank you once again, and I wish you all good luck. Thank you very much.
Thank you.
Thank you.
Goodbye.
Stay safe.
Yes, that's very important. Stay safe, stay healthy. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye.